Our outlines and objectives for today are, we've already had our introduction. We will be talking about the understanding the layers of structural inequity. Why did Holk assessment occur? How are these practices reinforced by policy? Better understand how past policies have shaped current health inequity, so bringing that piece together. Defining health equity, just an inclusive society where all communities and people have equal opportunity to access and optimal health. Considering how the past can inform current equity work, taking a look at the Holk maps and infant mortality, and then moving on to breastfeeding disparity. And then some next steps. Where do we go from here? So in order to do this and to begin the conversation, we really do need to delve more into the understanding of the layers of structural inequity. What are we talking about? You see two different definitions here. Structural inequity is defined as a condition where one category of people are attributed an unequal status in relation to other categories of people. You also see the definition of the social determinants of health from the CDC in 2014. And if you take a look at this definition, the complex and integrated and overlapping social structures and economic systems that are responsible for most health inequities. These social structures and economic system include social environment, physical environment, health services, and structural and societal factors. One of the reasons that we chose this definition is because this is what defines social determinants of health by the CDC for public health policies. It also points out, if you see in bold, that structure is bolded 3 separate times. This is going to be important as we go on in our conversation. So what are some of the differences? If you take a look at this slide here, we chose this because it shows a difference between what we're talking about with equality, equity in the middle picture, and then the reality. You take a look at equality, it basically defines that everyone gets to have the same box. They get to stand on the same box, but you see the different height of people standing at the fence. One person who has a clear view, one that has an optimal view but not great, and then the other person that has no view whatsoever. You move into talking about equity. That's a different type of distribution. So you see that everyone is standing at the fence at the same height, but you notice with the second and the third person, there needs to be different levels of boxes, whereas the first person doesn't need to stand on that box at all. And then we talk about what the reality is currently. And the reality is that there are those in a benefit system that have several boxes that they get to stand on, a person that will have one, and then a person that's actually below the ground. We're starting out with very little access to resources or opportunity. So when we begin to talk about our conversation in regards to historical segregation and its impact on infant mortality, we really have to put it into context of taking a look at an almost 400-year timeline. In 2019, we will be at 400 years in a historical context for the beginning of the enslavement of Africans through the transatlantic slave trade. And if you take a look at this timeline, it kind of gives you a breakdown of what that historical connotation is, from slavery into a very brief period of Reconstruction, moving into servitude, or what we know as the Jim Crow era, Civil Rights era, which began in 1954, earmarked by Brown versus Board of Education, and then post, moving into what we have now, which is present, which is the post-civil rights era, where we really start to talk about more of these structural racism concerns and issues that continue from historical policies. African-American citizenship status, this just gives another opportunity to be able to really take a look at it from a numbers perspective. And I want to draw attention to the very last portion of this grid, which states right there in 1619 through 2017, a struggle unfairness. We're talking about 398 years. That's 100% of the U.S. experience for African Americans. So why are we pointing out these structural inequities, and what are some of the levels of importance? We have to begin and talk about the institution of chattel slavery itself. To give a little bit of a background in that, the reason that this period was referred to, and in particular for enslaved Africans that were brought to the United States, per context of our conversation. Chattel slavery is defined by being an enslaved person and knowing that you're going to be enslaved and that your children are going to be enslaved and that your children's children will also be enslaved. So chattel slavery is intergenerational. There was absolutely no opportunity, unless it was through some other mechanism, which was very rare, for your family to ever be brought outside of the slavery context. And it was a guarantee that children that were born into the system, why we chose this picture, is that they would also become part of that commodity. Then moving into Jim Crow and segregation. Jim Crow and segregation also continued to perpetuate, even after the ending of enslavement through the 13th Amendment, continued to perpetuate levels of inequity. So we continue to see this benefit-oppressed system where one group of individuals continue to benefit from a system that oppressed another group of individuals, very specifically talking about the white-black disparity in this country, and how that continued to define significant policies that were put into place. So that is where we're talking about some of those levels of institutional racism that we will get into a little bit further in this conversation. One of the main reasons that we wanted to make sure that we give you an accurate timeline and discuss Jim Crow and segregation before moving into the Homeowners Loan Corporation is because it is imperative to understand and make the connection between the two. Just to give a little bit of background in history, previous to the establishment of the Homeowners Loan Corporation, most home ownership was all based upon a 50%. So anyone could purchase a home as long as you had 50% down to be able to purchase that home. In the context of establishing the Homeowners Loan Corporation, it was the opportunity to supposedly allow for home ownership on a much easier level. However, to be very clear, Homeowners Loan Corporation and those policies that were enacted are the same types of mortgage lending and loans that we have currently today. So typically it's anywhere between a 3 to 10% down, depending on credit rating, and area and those types of things. So just so that you have a context. With the establishment of the Homeowners Loan Corporation, however, one of the things that did happen was that there was a survey. There was independent audits of surveys of several different cities across the country. At this point, well over 200 that we've been able to find that created maps. These maps, as you can see here, and we did a side-by-side of the Baltimore area, give you an idea of where there were areas that were the most desirable to be able to give loans and those that were the least desirable that were able to have loans. In that context, you'll see that we have areas that are marked as green, blue, yellow, and red. Now, most of us know, if you think about it, even from just a very simple aspect of a traffic light, green means go, yellow means pause or caution, and red means stop. So when you take a look at these maps, you can see very distinct areas that are given the go-ahead or the green light to be able to approve loans. And then you have very distinct areas that are given the red light, which means that they are not necessarily eligible for loans, or those that live inside of those areas will have a significant challenge being able to get those loans. Here's one other major point that needs to be discussed and remembered as we move further. Not only were the people in the areas that were in the green areas able to get loans for their own residential properties, but they were also eligible to get loans in other areas. So in the blue, and the yellow, and the red, those that lived in the green-lined areas were able to get loans to be able to purchase properties in those areas. But the people that lived inside, and the population that lived inside of what is the red-lined area, did not have access to those same loans. And typically, as we'll see in the next slide, those neighborhoods were predominantly poor and African-American communities. Now, this survey, again, was all subjective. This was based off of whoever the independent auditor was that went in to survey these cities and would make the decision based upon visually what they saw in neighborhoods. To give another example, and just to be able to clarify some of this as well, and to support some of what it is that we're doing with our work ongoing, if you take a look at this area description, specifically this one is from Philadelphia, and Dr. Gwen Sharp. You talk about what the detrimental influences are, or the things that would actually determine whether or not that area was eligible for a loan or whether it was a good investment. And you look at here, you'll see in number 5, the inhabitants. Predominantly laborers or relief. Foreign-born would be Italian. In E, you'll see an infiltration of Negro. That means in that aspect, according to how the area descriptions were utilized in determining loan origination, it was a concentration of undesirable low-class whites and Negroes, which meant that if you lived inside of that area, you were a high risk to give a loan to. So going back to that, and I know there's a lot of information to have to impact. I know there's a lot of information that's impacting this conversation and have to unpack in and of itself. But if you take a look at this grid, we have some of the historical examples of the structural determinants that create disparate social determinants of health for certain populations, just trying to pull some of this conversation together before moving on. If you take a look at this timeline and the grid as it's set up, you see slavery moving into Jim Crow, which moves into and develops this redlining policy. Redlining policies impacted housing, which, as we all know, one of the major social determinants of health is affordable and stable housing for a population. It impacted housing not only within the Hulk context, but it also influenced the development of policies that came from the FHA and the GI Bill, which ultimately led to levels of segregation, development, and reinforcement of neighborhood demographics and impacted education. So in short, one of the things that we'd like you to keep in mind as you're moving forward to my esteemed colleagues, we need to really understand that while we're talking about the social determinants of health, affordable housing in particular for our conversation, poverty, access to transportation, access to employment, et cetera, we really have to get down to the conversation of understanding that without addressing and changing the structural determinants, i.e. those policies that are institutionally enforced, we will not be able to address the social determinants of health. And now I'm going to pass this on to my colleague, Brittney Francis, for the next section of the lecture.
Good afternoon. So carrying on in line with what Jessica was saying, we know that there were a lot of private, sort of subjective firms that would come out and would contribute to racial segregation. We know that racial segregation in many urban cities and even suburban areas were originated through private action, but something that we want to make clear through our presentation were that these private actions were sustained, embedded, and even reinforced by public policies. So here are a few public policies that sort of that are considered historical drivers of racial segregation within neighborhoods and reinforced racial segregation and allowed for isolated opportunities in certain urban spaces. So the first I'd like to focus on is zoning. And so this is the idea of density restrictions. And so in some ways, it would isolate parts of communities. Particular land uses practices would only be either commercial or residential. And so a lot of times we think of zoning as isolating poverty, but really, in fact, it's isolating wealth in certain areas so that certain people would not have the opportunity to gain access to them. Jessica just spoke about redlining, and so when you think about redlining, you also have to think about investment practices. And as a consequence of redlining, neighborhoods that did not have local banks or that banks deemed unfit for investment were usually left. They were left underdeveloped. They were usually left in despair. And so they didn't have local businesses to drive property values. And so without people moving in, property values would decline. You'd have increase in vacancies. And so then this would go on to the next point of urban renewal. When you look at urban renewal, public housing, and federal highways, when you see these particular communities that are seen as blighted, what would happen is the federal government or local government, state government would offer incentives to different people to go into these communities, these urban communities, and revitalize them. A lot of what we call today is gentrification. And so not only would it revitalize the community, but it would also disproportionately affect the people that were living there, because then they were no longer able to afford the housing that was available there, and they weren't able to take opportunity of the things that were now created in their neighborhood. And so they were displaced. And so we have families displaced, we have communities displaced, and then they have to essentially start over again in terms of social networks. In addition, the federal highways oftentimes would come in and destroy communities. They would be put in the middle of communities, or they would block communities' access to grocery store. One primary example is in a lot of major cities, you have public housing in urban areas on one end of the highway in the middle, and then on the other side, you have booming industries, grocery stores, access to fresh fruit and vegetables, but the highway serves as a barrier that these urban communities cannot actually access those resources. And then finally, when we look at just explicit racial discrimination and intimidation practices, whether this be through policies like exclusionary policies through the GI Bill, where veterans came home, they had equal access to the GI Bill, but African-American veterans were not able to utilize their GI Bill in the same capacity, and so they were not able to purchase homes. And we know that moving forward in terms of social determinants, as Jessica stated, stable housing is a key driver in terms of social determinants, but it's also a key driver in terms of intergenerational wealth and building wealth. And so that starts to lay the framework for how we can look at the disparities across the social determinants of health. So we are really interested in understanding how this all played out in terms of public policy and what it looks like in the city where we are today. And as being based in Columbus, we decided obviously to start with looking at previously HOLC assessment in the Columbus areas and how that relates to health outcomes within our own community. And what we found was that there is a corridor that goes along the middle of Columbus that was primarily redlined, where the outskirts are green and blue. When we take a look at current health outcomes, such as life expectancy, we see that it follows that same trend where the lowest life expectancy actually follows the trend of where there were previously redlined communities. Red being the lowest life expectancy, 64 to 72 years of age, and purple being the highest. And if you remember from the previous, primarily in that northwestern corridor where we have a large amount of green and blue-lined areas, we're seeing the highest life expectancy in Franklin County, which is also Columbus. When we take that a little step further and we then begin to look at infant deaths, and we look at aggregate births in Columbus from 2011 to 2014, we see that same trend happening, where red being more infant deaths per square mile in an area and blue being less infant deaths, we seem to have that same trend where along the middle corridor we have increased infant mortality, and along the suburban areas and the outskirts where we have the predominantly green and blue-lined areas, we have less or fewer infant deaths during that aggregate period of 2011 to 2014. If we then look at Neighborhood Opportunity Index, which is an index of successes or obstacles that are connected to upward mobility, it takes into account economic, educational, civic opportunity both on the state and the county level, and we think about employment in those neighborhoods, educational attainment rates, and we aggregate that into a neighborhood quality index, and we range it from very low to very high. We see that same trend that across in that middle section of Columbus, we're seeing very low opportunity, but in the outskirts in the northwestern corridor where we had the primarily green and blue areas, that we're seeing higher opportunities for housing, for transportation, for opportunity, health, safety, and most importantly, education. Prison admission rates follow that same trend. When we look, that same area that's being blighted and affected with increased infant mortality rate, low life expectancy rate, and low neighborhood index, also are being subjected to increased prison admission rates. Same with senior vulnerability. So if we're thinking moving from infants at the beginning of life to seniors at the end of life, seniors in these populations have very different vulnerability index. So if we look again in that northwest corridor, if you look, you see a lighter blue. And so light blue means that there's a low density of senior citizens and that their vulnerability is also very low. And if you go catty corner and look at red, it means there's a high density of seniors and that their vulnerability level is very high, which means barriers to access of care, reliance on Medicaid, needing family support. And if we look in that same corridor, we see more red than we do in any other part of the city. So what does that mean in terms of MCH outcomes? A concept that was developed in the late 60s and had a resurgence with Dr. Krieger at Harvard is this idea of the web of causation. Normally we think that a particular health outcome is caused by a singular factor. This risk factor causes this outcome. This exposure is linked to this particular outcome. But this is the idea that we've sort of been tackling with social determinants, is that it's not just one risk factor or exposure that contributes to a disease outcome or poor outcomes in communities, but it's a multitude of factors working together simultaneously to affect the outcomes in our communities. In particular, with infant mortality, we think about food stability, so access to fresh fruits and vegetables. Not even fresh fruits and vegetables, access to food in general. Education, so whether that be maternal education, paternal education, when we think about income, the neighborhood demographics, stable housing, access to care as it relates to prenatal care, we have to start thinking about how these things move in tandem, and that if we're developing programs and only addressing one pillar of this web, the others can still contribute to poor MCH outcomes. Right now, as I said, we think about social determinants, and we think about them in a way where they contribute, it's about living wages, quality of education, transportation, and availability of food. But what if we had a shift in thought? What if there was a new idea that instead of social determinants being an upstream effect to health problems, if it was more of a midstream effect? What if we thought that social determinants were created by power and wealth imbalances in our country? And those power and wealth imbalances come from the labor market, housing policy, educational systems, globalization, social networks, tax policy, things that are more higher level. So not on a community level, not group level flaws, but literally imbalances that are created from structural causes. And what if these power and wealth imbalances were created because of root causes? And that goes back to our original point of structural determinants. When we're thinking about structural determinants, we're thinking about root causes that have deleterious consequences, and they create the conditions that we see today. So we have institutional racism, we have class oppression, and we have gender discrimination and exploitation, and those create the imbalances that we see today. And so working simultaneously together, not only social determinants being upstream, but now being a downstream effect of all the other structural determinants that are in play. Then our web begins to look a little different. Then we have to take into account that our web includes structural policies, that our web is influenced by slavery, that our web is influenced by Jim Crow, that these particular structural determinants and conditions are still having lasting effects on minority populations within the United States, and that without addressing them, we won't fully be able to address MCH outcomes. I'm now going to turn it over to Dr. Jaye to speak a little bit about equity.
And so all of us on this call, I think, realize the definition of infant mortality. But I like this slide because it says that infant mortality is a community mirror reflecting our collective capacity to protect and support are most vulnerable. So it means that we have a way of influencing this. Next slide. If we look at the infant mortality rate for the United States, this slide goes from 1980 to 2013. You can see that we've made some significant improvement during that period of time. Next slide. But let's disaggregate that line by black-white race. So we see in the middle the same line we just looked at on the previous slide. The black infant mortality rate is on the top now, and the white infant mortality rate is on the bottom. Next slide. We see this long-standing gap between black-white disparity. And usually, this is where our conversation about the disparity in infant mortality ends. We talk about black babies dying at 2 to 3 times the rate of white babies. Next slide. But during this period of time, because the white infant mortality rate has improved at a faster pace than the black infant mortality rate, the disparity ratio between the two actually increases. Next slide. Another characteristic of this long-lasting disparity that I want to make sure we are aware of is what I refer to as a time lag from survival. Next slide. So that if you look at 2014, the black infant mortality rate in the United States was 11.05, and we've improved on that a little bit, but we're currently experiencing historical lows for the black infant mortality rate. Next slide. But our historical lows for black infant mortality still remain higher than the white infant mortality rate was way back in 1980. So that this disparity ratio is just not about black babies dying at 2 to 3 times the rate of white babies, but it's saying to us that unless we change this pattern, that black babies in the United States of America are going to have to wait until the year 2049 to have the same opportunity of surviving the first year of life as white babies did in 2014. And we think that's wrong. We think it's unfair. We think it's unjust, and we believe very strongly that we can do better. Another characteristic of this disparity that I want to talk about is what we see with the achievement of healthy people goals. Next slide. So if we look for Healthy People 1990, our goal was that by the time we got to 1990, we wanted an overall infant mortality rate of 9, depicted on this slide by point A, a black infant mortality rate of 12, depicted on this slide by point B. And we can see that we exceeded, actually, that overall infant mortality rate goal for white babies in 1986, well in advance of the goal date. Next slide. For Healthy People 2000, our goal was that by the time we got to the year 2000, we wanted an overall infant mortality rate of 7, depicted on this slide by point C, a black infant mortality rate of 11, depicted on this slide by point D. And we can see that on this slide we exceeded that overall infant mortality rate goal for white babies in the United States in 1992, again, well in advance of the goal date. Next slide. For Healthy People 2010, what changed was that we had one goal for everybody, and that goal was an infant mortality rate of 4.5 by the time we got to the year 2010, depicted on this slide by point E. And we did not achieve that goal for white or black babies in the United States. Next slide. But what was significant for 2010 is that for the first time ever, we achieved our 1990 black infant mortality rate goal. That means that 20 years after that original goal date, we achieved our Healthy People 1990 goal for black babies. Next slide. For Healthy People 2020, you all know that our goal now is to achieve an infant mortality rate for everybody of no greater than 6 deaths per 1,000 live births by the time we get to the year 2020. But understand that one of our overarching goals is to achieve health equity and eliminate disparities where infant mortality and other Healthy People 2020 goals are concerned. Next slide. So for that Healthy People 2020 goal, again for white babies, we achieved that goal back in 1998, again well in advance of the goal date. Next slide. So what we've done as a nation is we've achieved white infant mortality rate goals well in advance of the goal dates, and simultaneously, we don't achieve black infant mortality rate goals until long after the goal dates. So the numbers at the bottom of the slide are, when I'm giving this lecture live, I ask people, if I ask you to tell me the next number after 2, 4, 6, 8, of course everybody says 10, or 5, 10, 15, 20, of course everybody says 25. And we can reliably predict what the next number is going to be based on the behavior pattern of the numbers that precede it. The same is the case in this nation, unfortunately, regarding infant mortality, so that we know that if you're white, and we have established goals, the likelihood of achieving that goal well in advance of the goal date, based on almost 4 decades of data, suggests that we're going to be able to accomplish that, and that simultaneously we're going to not achieve the goal for black babies until well after the goal date. Next slide. There are a lot of us who still believe that despite data that shows different, that the black infant mortality rate cannot improve, and that it's as bad as it is because of group-level flaws amongst those of us who are black. Next slide. But there's no natural science to support this group-level flaws amongst black people are responsible for the disparity. Next slide. So I think there's room for us to legitimately pose this question. Do black babies in the United States of America really matter? Next slide. And though all of us say yes, there's room to suggest that our actions don't support this response. Next slide. Next slide. We've gone over this one already. So I'll turn it over now to Brittney.
So thinking through the historical context, thinking through equity and the patterns that we've created, how can we then, through the lens of historical perspective, inform current health inequities in maternal and child health outcomes? How do we move forward? How do we then show what we should be doing and informing interventions moving forward based on our past? And so that's something that we sought to do with our research. During the past year, Dr. James, Jessica, and myself have been doing research looking at the link between historical housing practices and healthy start sites, particularly looking at Holk assessment and redlining. So the primary objective of our research was to use geospatial methods to examine how many of the current 100 funded healthy start sites are currently located in previously Holk assessed areas. And so to do that, we developed foundational maps for ongoing research between increased IMR and historical housing practices. And we've done a little bit of secondary analysis since this project has originally started. While we understand that there are several, more than 100 cities in the U.S. that have increased infant mortality, we decided to use Healthy Start as a surrogate measure because in order to qualify to become a Healthy Start site, cities have to have at least 1.5 to 2 times the national average. And so it was a good marker, not of the only cities that are affected, but of some of the most high-risk cities in the United States. So the methodology for this was we first identified and geocoded all of the 100 Healthy Start sites with a little bit of help from John Snow and also the National Healthy Start Organization. And then we utilized those geospatial maps to develop a national map of the previously Holk assessed areas. And then based on those 2 maps, we overlaid them using geospatial analysis and qualitative research methods. And we reviewed archived city reports, area descriptions, and you saw an example of that before that Jessica showed you, resource mapping, reinvestment plans in these various communities, and we overlaid them to see what the patterns were in these communities. So this first map that you see now is just a geographical distribution of all 100 Healthy Start sites. If you notice, a large portion of them are in the Midwest and a lot to the eastern and southern part of the country. And then you have a decent distribution to the west, mainly in California. And so what we sought after was to find out how many of these 100 were actually in previously Holk assessed areas. And what we found was shocking. We found that 70 of the current 100 current Healthy Start sites were previously in HOLC-assessed areas, 70%. That means 70 out of the 100 programs that are currently operating are operating in cities that were historically marginalized through a federal policy to decrease and limit the amount of opportunities that Black and minority families had in terms of housing, and that recreated itself and introduced disparities in education and wealth. 70% of these sites are operating in these types of communities. So I want to just pass it over to Kiddada and Jaye, and they're going to speak a little bit about the historical impacts, similar on infant mortality rates, but on breastfeeding rates.
Thank you, Brittney. Jaye and I would really like to thank Dr. James for inviting us to be a part of this webinar. As we continue along this path, we'll take a moment to build upon the context by looking at the ways that historical events have affected Black breastfeeding rates in relationship to space and place. I want to take you on a journey that does not start here in America, because the start of Black history begins before the American experience. Throughout this journey, we'll take a chronological tour of how historical trauma has impacted Black breastfeeding rates, causing there to be a 14.7% breastfeeding initiation gap between Black Africans and national rates. This is a depiction of Isis breastfeeding Horus in Egypt, an African country. The ancient Egyptian goddess Isis, whose name means throne, is worshipped as the ideal mother and wife. She is often depicted as the mother of Horus and is shown nursing him in countless statues and drawings. The Egyptian goddess is the symbol of motherhood and protection, nursing her son. In traditional West Africa, there is no known breast milk substitute. Here is a depiction of the Middle Passage, a journey made by enslaved Africans as they were captured and brought to America on the slave ship. As you can see, there's no room for exercise and physical movement. In this place, one has to eat, sleep, and defecate. In this same space, I want you to take a moment to imagine what this means for a pregnant or breastfeeding mother. Slavery redefined breastfeeding for Black families. What was once known as an act of love became a brutal slave experience. The slave master arranged marriage and planned births. When slaves were allowed to nurse, weaning was forced to interrupt child spacing. Routinely, slaves were forced to nurse their master's child, making this experience of breastfeeding become viewed as a health necessity and not a love experience. Also, consider what this means for the psyche of the wet nurse, who had been forced to wean her child so that the master could receive adequate nourishment. For other slaves working in the fields, the workload was so strenuous that it impacted their ability to produce quality milk and keep up a good milk supply. You see, your milk supply is built upon a supply and demand basis. Breastfed babies must be fed on demand. However, the number of times the slave was able to feed her nursling was limited because of her workload. In fact, she returned to work the day after birth and being forced to leave her infant with supplemental food while she worked. Let's fast forward a little bit to post-slavery and during World War I, when mothers and children continued to be separated, and many black fathers were away for war, causing mother and baby to be separated for even longer hours as mother worked more outside of the house. Furthermore, many families moved northward bound for work, leaving Black babies in the care of their older family members. In 1946, Pet Milk began a targeted marketing campaign focused on Black families, using the infamous plump and healthy-looking Folks quadruplets as ads in Ebony magazine to boast the benefits of pet milk as the source to grow your child healthy and strong. Strategic marketing continues to disrupt breastfeeding. A few years ago, I saw an advertisement in Detroit, which is a Healthy Start locale. This is a huge display located near the street curb in front of a corner store. It reads, free diapers with any 5 cans of powder baby formula and 32 cans of baby food or 36 ounces of cereal. The target of this advertisement is clear. Women who live in the community, mostly Black women, and those who qualify for WIC packages is their target. The alarming thing here is that the messaging and reward incentivizes the families in the community for using infant formula. Next, my esteemed colleague, Jaye Clement, is going to tell you about how we're addressing these issues within the city of Detroit.
Thank you. So one of the things that is critically important is normalizing breastfeeding and providing socially and culturally relevant support for breastfeeding mothers, like the work that Kiddada does with the Black Mothers Breastfeeding Association, and like the work that I'm involved with the Women Inspired Neighborhood Network in Detroit, particularly for African American mothers because of the disparities we see in their breastfeeding rates. We have to ask how are staff being trained and what resources are being made available to support appropriate breastfeeding care and opportunities. Preparing a woman for breastfeeding has long to deliver. In fact, it should begin before a woman even considers pregnancy. Women need education as well as their support partners to understand the benefits, opportunities, and perhaps even to plan around expected challenges before they arise. In Detroit, we are very supportive of baby-friendly hospitals, and Kiddada and I both work closely with the Detroit Institute for Equity and Birth Outcomes on the notion of making Detroit a baby-friendly city where all of our birthing hospitals will have earned the baby-friendly designation. We're looking to normalize breastfeeding even more and also working with the community in real time to ensure that there's a demand for this type of support. In doing this work, we've also come to the realization that the term baby-friendly can in some ways isolate mothers themselves by neglecting to address their critical role outside of the literal and quite obvious one of offering their breast. For that reason, we've begun work on a new concept of restoring honor in motherhood, removing any associations of guilt, blame, or shame that is too often a burden borne by African American women in particular as a way of disrupting racism. So as part of our work as fellows with the W.K. Kellogg Foundation's Community Leadership Network, Kiddada, Valerie Jiggets, and myself work together to have a comprehensive plan for designing a mommy-friendly Detroit. The tenets of being mommy-friendly include racial equity and healing, community and civic engagement, reflective and responsive feedback that is culturally relevant, open communication, and health in all policies. We are working closely with a group of advisors and community partners to finalize a full toolkit and a community-based organizational assessment. We're planning an official launch to coincide with the National Black Breastfeeding Week on August 26th. Just to summarize this Mommy-Friendly Detroit concept, Mommy-Friendly Detroit is our plan to directly disrupt racism through the celebration and honor of Black motherhood. Consider this a paradigm tsunami. Watch the focus of care shift to ensure that mommies and babies are at the heart of it all. We are going to help organizations and providers prioritize mothers by way of their practices and policies. Mommies are a huge part of the plan. We are committed to helping them recognize and embrace their values as mommies within the city of Detroit. Just imagine how glorious Detroit is going to be with mothers and providers working together harmoniously. So I'm going to hand it back.
So this is Dr. James again. Before I go on, I want to thank NICHQ and AMCHIP for providing us with this opportunity, and I want to thank the wonderfully talented lecturers who were part of this presentation. I also want to thank all of you who have been a part of this webinar. Where we go from here is a big question that all of us have, and the summary that I'm about to give is not intended to be exhaustive, but simply to give us a few things to think about. All of us are accustomed now to stating that place matters. Similarly, we hope, especially after this presentation, that everyone understands that history also matters. I think all of us realize that we are currently experiencing a real threat to entering a period of retrenchment when ideology, politics take priority over people and the public's health. A time when pristine science and evidence-based conclusions take a backseat to other things. This makes all of our work much, much more difficult, requires that we not only work smarter, but that we also have to work harder, and that our efforts need to be local, statewide, and national. I generally recommend to people to start where you are in your spheres of influence, your family, friends, social contacts, your church, your job, in your neighborhood, being careful to always tell the truth and with an intent to change the narrative about what the causes are for the disparities that occur. Blend interventions to include clinical and non-clinical interventions, understanding that much, not all, of the clinical language we traditionally use, like preterm birth, congenital anomalies, or sudden unexpected infant death as the causes for infant mortality, did not capture all the causes for why babies die. That in some cases, these clinical causes are often the consequence of those non-clinical contributors. Speak up. Tell the truth. That is especially important during this time in our history. 2018 is an election year, so not only is it important to vote and to empower others to vote, it's also important to find a way to make disparities a campaign issue. Challenge candidates to provide their understanding of what accounts for the differences in outcomes and indicate what they propose to do to improve things. On slide number 6, Jessica reminded us that where African Americans are concerned, that we need to remember that the majority of our ancestors entered this country beginning in 1619, and that slavery and Jim Crow together still account for 87% of the African American experience. Remember to take that into account. Also remember that in just 1.5 years, in the year 2019, the United States of America is going to have to, in one way, shape, form, or a way, account for the 400-year anniversary of slavery. We should begin to change the narrative about our existence here to provide an explanation that helps people understand that the differences in outcomes experienced in this country is not natural and that it is man-made. Although this presentation concentrated on the black-white disparity in infant mortality, similar disparities are observed amongst Native Americans, in many rural communities, amongst the poor, and in my opinion are similarly man-made and not natural. Because we created the circumstances that cause these disparities, it's within our power to fix them. Collaborate, not only with organizations and other domains, but we also need to figure out better ways for all of us in the MCH world to work together better and to support each other. We need each other more in today's political environment than we have in recent history. The complexity of the challenges that we face ought to compel a higher level of collaboration. Stay the course. We've been improving the disparities in the last decade. Some of us have been very discouraged by the current discussion regarding the Affordable Care Act and the cutbacks in many of our safety net programs. But despite these challenges, find a way to stay the course. Remember that doing otherwise increases the risk of our babies dying, and we can not allow that to occur. Finally, aim for equity. Equity needs to be our North Star in all domains, not just where infant mortality is concerned. And our motto, in my opinion, ought to be that equity is primary and that all else is derivative. Thank you all very much.
Thank you very much for that wonderful presentation. We will now open the session up to questions from the audience. We've received several, but if you do have a question and you haven't chatted it in yet, please feel free to do so. Please note we might not be able to get to everyone's question due to the time constraints, but we do have about 25 minutes for questions. Our moderator for this portion is Zandra Levesque from NICHQ. So I will hand it over to her, who will help moderate the questions that have come in so far.
Thank you so much, Lee, and thank you, Dr. James and Brittney, and really everybody. This is really incredible, and your call to action at the end was really powerful, and so we really appreciate it. We appreciate your time and all that you've done. And so at this time, I'd like to, we have a question from Marianne Honors. Could you describe the Neighborhood Opportunity Index and Senior Vulnerability Index? Are these data available on a state level for all states? I believe this question is for Jessica and Brittney.
So this is Brittney. So in developing the Neighborhood Opportunity Index, that is not available on a state and local level. So that was developed in-house here at Kerwin. So we have a staff member that does really, really great geospatial analysis. But essentially he took various markers, so looking at educational attainment rates, barriers to education, grocery stores, things that would define what would allow you in your neighborhood the best opportunities to succeed, and developed a marker from that. And then from that, we created a gradient that was lower high, and based on that gradient, we then developed that map of the opportunity index. I think it's something that can be created for any community. I just think it would be a matter of developing the proper methodology, and maybe that's something that we could share from Kerwin with other state leadership or even, local or professors in academia if they wanted to sort of recreate that for their own cities. And then as far as the senior vulnerability, a similar aspect to the neighborhood, but specifically tailored to seniors in that area. So in terms of reliability for transportation, so if they're relying on public transportation to take them to and from various visits, opportunities for them to be able to participate in senior programs. So there are programs out there that cater toward arthritis. It's like Walk with Ease. Are there places in these communities that allow them to participate in these sort of programs and allows them to be successful and decreases sort of their morbidity as they're moving through their chronic stages? And so similarly, we developed this index from low to high, and then we also looked at the density, so the number of seniors that are in particular pockets of Franklin County per population rates of the county as well. So looking at the concentration of seniors in an area and then looking at the opportunities that they have to succeed within those areas.
Thank you so much for all that information. And we certainly will take you up on the offer of sharing those. As you probably know, our motto is sharing seamlessly and stealing shamelessly, so the more we can help each other, the better. So thank you. And I'm going to move on to question number 2, and this is from Janet Jones. And so her question is, knowing these structural policies have created the inequities in infant mortality in America, what are some tangible changes that institutions are able to make in order to create change and equity? And I believe this is given the topic of today's call, really aimed at all of you, and I know that Dr. James provided some specificity at the end, but any additions and thoughts? And and before I let you answer, if anybody on the call wants to chat in what you are doing at your different institutions and that can help, please chat it in and we'll be able to share with everybody after the call. But I'll turn it over to our presenters.
Do you want to answer that, Jesse? So I think one of the things one of the points that we've tried to make here is that we need to look beyond only attempting to address clinical interventions as a way of improving infant mortality and decreasing or eliminating the racial disparities in birth outcomes. That there are conditions that we've created, and those conditions have consequences, including increased rates of babies dying during the first year of life. So that part of our intervention strategy needs to move more upstream to address things at a policy level. At policy levels locally, meaning then that you engage your city and county councils, as well as your state legislators, and of course it requires us to be engaged and involved in policies as they are being developed on a national level as well. One of the things that we did here in the state of Ohio was recently, this past year, we had a couple of our congressional people within the state who formed a commission on infant mortality, and as a consequence of that, there were a number of policies that, as of December of 2016, were passed by our state legislators. Health Bill 332 in the state of Ohio, for any of you who want to look it up, that will allow us as a state to address some of the things that influence infant mortality. It wasn't all exhaustive. We couldn't get everything passed that we wanted, but it was a beginning, and a beginning in a way, again, of addressing things on a policy level. So that, for example, as of April of this year, it's no longer legal in the state of Ohio to sell bumper pads as a way of trying to decrease the risk of sleep-related deaths. And then there's several other things that were part of that health bill.
Also, in addition, I'm sorry, I apologize, it's Jessica Roach speaking. In addition to that, I think that one of the things tangibly that we can really start having conversations about, in particular, is how we conduct our health communication. One of the issues of having this discussion about Black race being a health risk factor versus actual racism being the health risk factor. We have to get very honest about those conversations. And so walking into a room, especially as an African-American woman who's pregnant and wanting to receive the best care possible, when the initial response is, here are all the things that you're at risk for simply because you're African-American, that can create a significant amount of stress upon the body from a physiological level. And I believe that we really need to get down to having these difficult, challenging conversations, that what we may have thought as far as these group level flaws are concerned, referring back to what Dr. James is saying, really is not where the conversation needs to be. There is no biological rationale or reason for us to have these infant mortality rates that we do.
Thank you, and a huge congratulations, Dr. James, in thinking about the infant mortality coin and the work that the states are doing to improve safe sleep. The bumper pads achievement that you mentioned is huge, and Jessica, exactly everything you mentioned. The communication is so important in our state. The states in the coin have expressed that over and over again. How do we, the power of words, and how do we use those to really impact change and change norms? I'm going to move us on to the next question, and this is from Angela Love. First of all, I love your name. So this is directed to Jaye and Kiddada. Voice your support for baby-friendly initiatives to the Detroit area hospital administrators. Yes, let me, have you voiced your support of baby-friendly initiatives to the administrators in the hospitals?
Oh, absolutely. We are avid supporters or advocates for baby-friendly hospitals, and we work very directly with supporting the prenatal education and training for providers. That work that I mentioned that we do with the Detroit Institute for Equity on Birth Outcomes, yep. It is taking the prenatal education for breastfeeding that goes along with the baby-friendly model into the community so that moms are being exposed to that messaging outside of just their prenatal care visits within hospital settings. So yeah, we're very much advocates and supporters of that work.
And I know this has come up and I'm going to take this question one step further, where I know that we continue to have questions from our state participants, and I'm sure others on the call will as well. Could you share some tips on how you've been able to forge those partnerships with the hospital administrators, maybe perhaps with the entire hospital association, and what are maybe your top 3 tips on how to start spreading your message, in your case is baby-friendly, to those decision makers?
So I have to say that we are fortunate that we've not had to force it in our community. We very early on identified physician champions for this work in our community, and their leadership has helped to elevate and keep these things going. So within Henry Ford Health System, I report directly to Dr. Kimberly Dawn Wisdom, who's the Senior Vice President over Community Health and Equity, who was always willing to be a champion. The first baby-friendly hospital in the Detroit area was St. John Providence, and Dr. Paula Schreck is well known across the country as well for her work in supporting breastfeeding. She's a pediatrician. And I think there's been some kind of public pressure to have this work go on, positive peer pressure in a way. So all of the health systems in the Detroit region are well connected. We have the Detroit Regional Infant Mortality Reduction Task Force, which is representative of senior leadership from all of our major birthing hospitals in the area. So this work kind of started out with built-in buy-in and support, which we are very fortunate to have. And that would be my advice to anyone, is to identify who are the physician champions who can carry the message and feed them all the talking points that you can and keep that going.
And if you're on the call and you're in need of some support in creating that message or that pitch for your different decision makers and partners, we would love to welcome you to reach out to us here at NICHQ, and we can provide some resources to support you in that. And I know our partners in AMCHIP, I can definitely speak for them that they also welcome you reaching out to them. Okay, so then we do have some limited time, but I'll move on to question 4. This is from Tess. Can you talk about the role of social media and how you use it in supporting these efforts? This is really directing this to everybody, but I think you were just talking to messaging and how important it is, so I guess this takes us one step further. Has social media played a role?
So in each of our initiatives with WIN Network Detroit and with Black Mothers Breastfeeding Association, we use social media as a tool of advocacy, as a tool of support and communication, and a way to get our message out. I think a key thing about social media is collaborative partnerships. For instance, for World Breastfeeding Week, which is the first week in August, Black Mothers Breastfeeding Association is working with other vibrant Instagram influencers to kind of take over our Instagram page. So that's one way. It's just really not looking at social media in a silo, but really thinking of social media on how can we collaborate. Particularly for Black Breastfeeding Week, which is the last week in August, the leadership for that, which is myself, including Kimberly Seals-Allers and Anaya Shangadole-Eyoka, we really work with collaborative partnerships for Twitter chats. We have people come in and do Facebook Live. We're doing an Instagram takeover. And so we really use messaging and making sure that messaging is culturally appropriate. As we use social media as a tool for social change.
Thank you, and that's so innovative and exciting, how you're able to invite, put your message to different influencers. I'm going to move on to a question from Colette. Given the modified web of causation presented earlier in the webinar, could you comment on novel ways in which researchers can study these interconnected and hierarchically related factors? So this is for Jessica.
Are you asking if there's suggestions for how researchers can be able to do this intersectional work and be able to take a look at all of these factors, including the structural determinants and how they influence? Perfect.
Yeah, that's exactly it. Yep.
Well, I have to start with, I believe that there already is a significant amount of research work that is being done and has been done in regards to this discussion, in particular about the independent variable of racism and the impact of stress upon mothers and infants. I can, a couple of researchers off the top of my head would be Dr. James Collins, Arden Handler. There is research work that is there. There is a body of evidence. If we're talking about levels of implementation, taking it to the next level, one of the things that we have to keep in mind, again, is that if we are going to utilize evidence-based practices, then we have to be able to acknowledge that these factors are real and that each individual's experience is valid. And it's important to consider as far as MCH overall and how it is that we conduct care. Moving forward, as far as research is concerned, there was actually, and I apologize, I don't have the name on the top of my head, but it was just recently published with a group of researchers, one of them being Dr. Jaye Clement from National Birth Equity Collaborative. And it was a mixed method, so qualitative and quantitative. So basically what you do with that is that you take information and the stories of women and the impact upon them and their experience in their reproductive life, where they come from, what type of stressors they have to deal with on a daily basis, and out of that you pull out themes using that qualitative method and find that there is a substantial, I mean, we don't live in a monolith, we're not monolithic, we all have our own set of circumstances, but there are some very significant themes that across the board are echoed by women, in particular African American women inside of communities like we're talking about with the historical redlining and segregation that are very much impacted by daily life. And I think it's really important to take a look at the work that has already been done and somehow start to really integrate that into the work that we're going to continue to do moving forward.
And this is Brittney Francis. I just wanted to piggyback off that, but also to think of sort of epidemiologically how we move forward in methodology and thinking about how we're modeling these. I think using more interactions, thinking about effect measure modification. So first off, making sure that we're collecting ample data that can be usable, making sure that it's good data that we can use in order to really look at the issue. So I know a lot of times we collect information about sociodemographics, and it's just, the question of, what's your highest degree? But really understanding sort of what that educational barrier looks like, what that social determinant of in particular, education looks like outside of just a socioeconomic demographic variable, and really figuring out how we can design models that will create multiple variables, whether it's through interaction, and then looking at those effect measure modifiers to really see if the experiences of people who have different experiences as it relates to that web, if they're modeling differently, if they're having different outcomes, if those associations look differently when we model those in particular situations and models.
And just as a close to add on a little bit more, unless Dr. James or Kiddada or Jay have something to add to this as well, I wanted to make sure that we have an opportunity to really land on validity. In research, we often have validated tools, and yes, we need to utilize those as we move forward, but when we're talking about the experiences of those of us in the community and what we may have had impact our maternal and child health, we need to really revisit that. This is not necessarily so much a new story as it is we're putting new measures to it, and we're taking a really close eye and shining the lens on something that has been a part of community experience for, as long as the timeline is that we had on one of our original slides. I think it's very, very important moving forward that we consider the impact and the influence of community-based participatory research methods and work together in order to really address from a clinical perspective and from a public health perspective how it is that we're going to start shifting these outcomes.
Thank you so much. And, we very well aligned. We have perhaps what we were last question given our time. As you're speaking about validity and making sure that we are taking into consideration what the data is telling us, we have a specific question from Katie Stetler. What are some ways that programs might be able to measure its work to address inequities through MCH programming, particularly when programs operate on a relatively small scale?
So this is Art James again. I think one of the important characteristics of any intervention that we do that attempts to address inequity needs to keep in mind one of those early slides that Jessica showed about equity, where it showed the little boys standing on the crates or boxes. One of the important notions of that slide that I think is important for us to incorporate in our intervention efforts is this notion of intentionally providing more help and assistance to communities or individuals that need the help the most. We get caught up in this whole notion of trying to be quote-unquote fair so that we do the same things for everyone across the board. And in fact, when we do that, we actually help to increase the disparities, because for communities that didn't need the help as much, we provide them with the same level of help as communities who need much, much more help. This notion is referred to as proportionate universalism or targeted universalism, and in my opinion, it is one of the most important components that we often leave out when we're doing this work. And I think not only in terms of money and resources, because I think that's the way most people think about this, but also in terms of the intensity of the actual work that you do and how many people you have doing that work. We have to bombard these communities who have been most challenged by some of these things with an increased, enhanced amount of assistance and help.
And this is Brittney Francis again. I wanted to add in terms of measures, making sure that evaluation, to go along with what Dr. James said, making sure that evaluation is built in from the forefront of programs, making sure that, again, adequate data is collected. A lot of times I know for some small-scale programs, there's a lot of evidence base that goes into it, and then you develop the intervention, but making sure that the baseline data that's collected is good enough so that on the back end, when you do have these programs to be able to address changes in these communities, you can show clearly how the program has actually reinforced the mission of the program and what steps you're taking to actually decrease that disparity gap and increase equity within those communities.
I would like to add just one more thing to that, if I can. Hi. This is Jaye Clement. Earlier, Jessica mentioned community-based participatory research, and I was thinking exactly that when she was talking. But one of the ways that we measure success is by involving the women and the families that we work with. So they are part of planning the intervention and part of planning how it will be evaluated, and they should also be a part of deciding and determining what's working, what parts of that work should be lifted up and what parts of that work should be modified. So I think it's important all throughout every process of our work to include the community's voice. Kiddada and I talk about this a lot because we are vulnerable Black women ourselves that live and work in a red line city, and our experiences across the community are so vastly different from one another. It's important to diversify the perspective and understand that we don't have all the answers and not pretend to, and let ourselves be open to hearing from and being included other voices when it's appropriate and needed.
And that's probably one of the best ways to conclude our call today. I just want to say thank you for that powerful self-reflection and a good reminder to all of us as we continue to do this work. We do have a number of additional questions that I want to be respectful of everyone's time. So to the presenters, would it be okay if we followed up and got some answers for our attendees and we can follow up with everybody? Would that be okay?
That would be fine.
That's fine.
Yes, absolutely.
And so I just want to say one more time, thank you so very much for your time, for your dedication to this work, and for your willingness to share with everybody. There are a lot of questions in here that I know not only the presenters have answers to, but all of you do. So for those of you who are participants in the Infant Mortality Coin, we'll make sure that they are included on the collab, so we can continue to have a conversation. And then when we will follow up with the recording, the slides, and the questions and answers. Thank you once again to those of you joining us from the West Coast. Hope you have a great rest of your day. And for those of you here in the West Coast, have a fantastic rest of your afternoon. And just a friendly reminder that this is the first and an amazing way to kick off our Infant Mortality Expert Webinar Series. Our next webinar is focused on learning from rare events infant mortality data. And a reminder that the topics that you will be seeing through this series really came from all of you in the field, and the challenges that you continue to grapple with, and the incredible lessons that your colleagues across the country have learned as they keep on doing this work. So we look forward to seeing you on the 22nd from 2 to 3 p.m. Eastern Standard Time. And I can't sign off without saying not only thank you to our participants, but also thank you to our partners at AMCHIP and to the Kellogg Foundation for making this webinar possible today. Thank you all, and with that, this webinar concludes, and we really appreciate your time.